All right, so it is my pleasure to welcome the speaker tonight, who is Andrew Campbell. Andrew is a Master's Qualified Audiologist, certified in Audiological and Neurological Sciences, making him the top in his field for hearing and brain health. Andrew is a speaker, teacher, manager, innovator, and author of what just became the #1 new release in health and sciences on Amazon. Very exciting. Andrew is one of the founding members of the largest hearing and healthcare groups within Australia, and now the founder of New Audio, Hearing and Brain Health. Andrew's work has been recognised multiple times in Australia, Malaysia, Singapore, Hong Kong, Taiwan, and the USA. So please welcome Andrew Campbell. Oh, study zone.
So good evening, everyone, and thank you for taking time out of your schedule to join us this evening. Did anyone travel any more than, say, about an hour to get here today? Okay, great. If I could put you on the spot there right up the back. You traveled, how long did it take you to get here? Oh, wow. And can I put you on the spot again and just ask, was there something specific that made you kind of get in the car and come all the way down here to, was it? Okay.
Yeah.
Okay. So lots of walking, yeah. Awesome. Very good. Was there something that you were specifically hoping to learn this evening? Oh, great. So just for the benefit of people online, she's feeling like she's getting on a little bit in age, and she coaches women in middle life. So hopefully there's some relevant things we'll be talking about this evening. So fantastic. Did anyone else come here with a really specific interest in mind of something that I'd hope I'd want to cover? Yep.
Good friend who, what I noticed first was his hearing, and I queried with everybody else, and he's since been diagnosed with Alzheimer's.
Okay. Okay. Right. Okay. So, so I'm guessing your interest would be to learn a bit about the links between hearing health and our cognitive health. Excellent. Great. We'll come to the right place, because that's really going to be the focus of the session this evening. We know that I'm going to be sharing quite a lot of research with you, and all of you have got a complimentary copy of my book where I go into that research in a little bit more detail. And the thing is, we know that it's whilst there's some really important research on the topic, we know that it's a subject that's not particularly widely understood in the community. There was a major survey done of the Australian public just to try to get a sense of, well, how well do Australians understand the links between hearing health and their brain health? And what they found was that 84% of Australians had absolutely no idea that there was any link between hearing health and brain health. So hopefully you'll leave here this evening with just at least a bit of a grasp of what these concepts are and how that all works. So in my 22 years of doing this kind of work as an audiologist, there's not been one week that's gone by where I've not come across the heartbreaking case of someone that's just simply left treating their hearing too late. So we know that most people here in Australia with a treatable hearing problem, they never set foot in an audiologist's office. In fact, only about a third of people that could benefit from having their hearing loss treated ever go and do anything about it. We also know that on average, there's a 10-year delay from the point where people could benefit from treatment to the point when they finally go and take action. And what the science is telling us that really is 10 years too late. We know from a practical perspective in treating hearing loss day in, day out in our clinics, that we just get our best results in the clinic when we catch hearing loss early and we treat it early. So much of the research that that we're going to cover this evening really was sparked in 2011, when it was really for the first time that hearing was involved in a major multi-million-dollar study of the aging process. So in this research done at Johns Hopkins University in the United States, there were 600 people in this study, all aged around the age of 60. And in order to be part of this research, they couldn't have had a history of having dementia. So they're coming in to this research dementia-free. They came in as what we call a longitudinal study. So it was done over a long period of time, in this case, over a 12-year period. So they came into the university every year for 2 to 3 days of intensive testing. And they were looking at not just hearing, but all sorts of things known to be associated with aging. So coronary heart disease, diabetes, cancer, male pattern baldness, arthritis. Hearing was just a very small part of what they were looking at. So they were coming in dementia-free, aged around the age of 60, coming out at the end, aged around 72. So over this 12-year period, huge amounts of data put together, lots of analysis done. And what the researchers found, that the most surprising and stunning statistics that came out of looking at all the health modalities were the clear links between hearing loss and dementia risk. What they found was that those people that had a mild hearing loss, so a mild hearing loss, it's about a 25% hearing loss. When I graduated from here, the University of Queensland, 22 years ago, we didn't really care so much about a mild hearing loss, but given what we now know, we are most certainly concerned about it. Those people that had a mild hearing loss in the study, they were twice as likely to have developed dementia over that 12-year period relative to their peers that had normal hearing. Those with a moderate hearing loss, so I've got a clinic at Ashgrove, and most of my patients there have a moderate hearing loss, which is between about a 25 to 40% hearing loss. Those people with a moderate hearing loss in the study, they were 3 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. And those with a severe hearing loss, so a severe hearing loss, it's around a 50% or more hearing loss. Those people that I mentioned earlier on that really had put off treating their hearing loss really too late for us to get a really great outcome in the clinic. Those people were 5 times more likely to have developed dementia over that 12-year period compared to their peers that had normal hearing. So these findings, they created quite a stir in the medical community, lots of media coverage over in the United States, front cover of the New York Times. Not a whole lot of media attention here in Australia, though I'd have to say that slowly but surely the medical community in particular is becoming better aware of the links between our hearing health and our brain health. So a couple of other statistics that have come out. I had the pleasure of meeting Professor Frank Lin, who is the head researcher of that study, and he was over in Sydney he came over initially about 4 years ago to talk about that research, and also I was fortunate enough to be part of some intensive training he was doing. And he was also over in I guess, a public health capacity, trying to bring hearing more into the forefront of when we're thinking about, particularly the physicians, when they're thinking about diagnosing someone as having cognitive decline, Alzheimer's, which is the most common form of dementia, because it's actually relatively common for people to be given the diagnosis that they've got mild cognitive impairment, cognitive decline, even dementia, and they haven't even had a hearing check. So, really in light of the research that we're seeing in this area, when cognitive decline is suspected, hearing really is the first thing that we should look at. So Professor Lin, back then he gave us a few more statistics that his team kept coming up with time and time again. One is that for every 25% of hearing loss, we see for every 25% of hearing loss, we see a 6.8-year premature aging of our cognitive abilities. So when I'm talking about cognitive abilities, I'm talking about things like short-term memory, our processing speed, general executive functions, capacities that we need to navigate day-to-day life independently. All of these become impaired when we've got a hearing loss that we've done nothing about. So round figures, if we're getting a 6.8 year premature aging of our cognitive abilities with a 25% hearing loss, that would suggest that on average, someone who's 66 years of age with a 50% hearing loss would have a brain age of an 80-year-old. Also, untreated hearing loss has been associated with an acceleration of cognitive decline by 30 to 40%. And, if we're thinking about, well just why is it that our hearing health, how could it possibly relate to our brain health? Well, in a nutshell, there's really three main mechanisms at play. One is that relate to social isolation. So we've known this for decades, that hearing loss is strongly correlated with an increased risk of chronic social isolation. Chronic social isolation, it's twice as deadly as obesity. You're better off smoking 20 cigarettes a day than to be chronically socially isolated. It's actually quite a big deal. So what tends to happen when, probably the main complaint that we get in the hearing clinic day in, day out is difficulty hearing in background noise and group situations. So most of my patients, when they come in to see me for the first time, they're okay hearing me one-on-one in quiet, but as soon as they get out to cocktail party, family function, restaurant, cafe, that's where the majority of the difficulties happen. So it can get to the point where it can become potentially embarrassing to be out in a social situation and really and mishearing. You might, laugh at something that wasn't a joke, or mishear something embarrassing, for instance. People tend to start to feel like they're on the periphery of the conversation, not really directly involved. There becomes a point in time where people have about enough of that and start to disengage from those social interactions, those activities that they would otherwise like to be a part of. And that's the point where we start to get really concerned about it. So chronic social isolations, it's a whole set of considerations. Secondly, we've got those that relate to what we call cognitive overload. So following conversation, particularly in a background noise environment, is one of the most cognitively demanding things that we do. And when we're not hearing words in full, it becomes that much more challenging. So for most people, like over 90%, particularly that I see in my clinic, it's not like they're hearing no words, they're hearing parts of words. Most commonly, they're hearing the vowels, the lower pitch parts of speech, all of the A, E, I, O, U vowels, but they're not getting the higher pitch consonants, which typically carry most of the meanings of words, and we'll get into that a little bit later. So when you're not getting all the consonants, in order to communicate, you need to get that information from somewhere else, most typically from your vision. Body language, facial expressions, movement on lips, they all give us clues as to what that person might be talking about. Sometimes that's not enough, and we need to think of the context of the conversation so we can get the gist of what's being said. So we're putting the bits together that we can hear with the bits that we can see, adding in that context. Hopefully we've got enough to follow that conversation. Ask anyone that has a significant hearing loss, what's it like for them at the end of the day after interacting with groups of people in challenging environments, and they'll tell you that practice can actually be quite exhausting. So the third set of factors relates to what we call, well, the medical terminology is cerebral atrophy, which is another term for, we can say, brain shrinkage. So with untreated hearing loss, we can see up to 40% reduction in the volume of parts of the brain associated with speech, hearing, language, and memory. We can also see some disorganization effects occurring in the hearing centers in the brain, and I'll show you what's going on there in a particular study shortly. So you might be thinking, well, gee, thanks, Andrew. I've come, all the way here, up to an hour and a half away. I could be, sitting on the sofa and having a chat with the family, or doing something fun, and you've invited me to come here and listen to you talk all about doom and gloom. Well, the good news is that when we can apply the correct treatment to that hearing loss, we can actually see a reversal of a number of these downstream trends. So I'll just on the cerebral atrophy aspect. So in terms of when we're thinking about brain volume, up on the screen here, and hopefully you guys online are able to follow this okay. But the bars here that what this is looking at is difference in brain volume in people that have normal hearing versus those that have a hearing loss. And these bars represent, so the higher the bar is, the more brain volume we have. Where we see the most noticeable differences in brain volume in people with hearing loss versus those with normal hearing is in part of the brain that we call the right cluster, which is kind of like adjacent to the ear. It's where we've got the most important speech centers in the brain. When we compare the right cluster of people with normal hearing, so this far bar here in blue, these people have normal hearing. Next to them is people that have a hearing loss. So you can see that reduction in relative volume there. And we can actually see differences in whole brain grey matter in people with hearing loss versus those that have normal hearing. Here again in blue, people with normal hearing, that bar is higher than those that have normal hearing, so those that have a hearing loss. So we can see up to a 10% reduction in grey matter in people with untreated hearing loss. This is an example of just a single gentleman who is 68 years of age, and he's got normal hearing in one ear and a severe hearing loss in one ear. And on the severely affected side, just above that red arrow there is, you can see there's a bit of a reduction in volume relative to the other side. So on a brighter note, looking at some studies that have looked at, okay, what's happening in the brain with people that have untreated hearing loss, so they haven't worn hearing aids before. But I should mention, when we're talking about treating hearing loss, for the most common forms of hearing loss, which are a permanent hearing loss, the most effective and appropriate treatment for that kind of hearing loss in this day and age is, in fact, hearing aids, or we like to call them hearing devices. This seminar is not about ramming hearing aids down your throat or anything like that. It's to just hopefully give you a clear sense of, well, just how is our brain getting involved in all of this. So in this particular study up on the screen, there were 14 people in this study, and they had a moderate hearing loss, so about a 25 to 40% hearing loss. So the thing that's the most different in the brains of people that have untreated hearing loss is we see an overactivity in this frontal part of the brain here. And we can see that visually here in this study. So the thing that's the most different so it says pre-hearing device fitting up the top. The thing that's the most different is this overactivity in the frontal part of the brain there. They actually saw some relative shrinkage effects in the hearing centers in the brain as well with these people. So they received what we like to call the holy trinity of the correct treatment of their hearing loss, which is good quality and appropriate for them hearing devices. They were fitted correctly, so fitted using best practices, which we always use and which should always be used. And most importantly, they kept their devices in for at least 12 hours a day. The thing is, we know that most people that own hearing devices, particularly here in Australia, we know that most people don't wear them. We know they don't wear them because they've got little databases on them, and we check. Major study, 15,000 hearing aid owners here in Australia, looked at database usage of how often these people were wearing the hearing aids. And they found that a third of them really weren't wearing them at all. They were in the bathroom cabinet, sitting in the top drawer. Some people even wear them in their pocket. If they were wearing them, it was for a maximum of 2 hours a day. Another third of hearing device owners in this study, of 15,000 owners, found that a third of them were what I like to call reading glass wearers. So they'll pop the devices on maybe to come to a session like this, or potentially they're out with the family watching TV, something like that. Most of the time they're not actually wearing them. only a third of people that own hearing devices here in Australia actually wear them as they should, which is at least 12 hours a day. So if you've got hearing devices, if someday you need them or you know someone that has them or needs them, the best advice that any audiologist can possibly give you is that those devices really need to be in ideally for at least 12 hours a day. The best evidence that there are brain health benefits in treating hearing loss comes from these important studies where people really consistently utilize the treatment. And I can tell you from a practical point of view, in having done this kind of work for over 20 years, the difference between a patient that has got into the habit of keeping their devices in for at least 12 hours a day versus someone who views their hearing aids kind of like their reading glasses, wears them occasionally, the difference in outcomes that we get, it really is like chalk and cheese. So these people, they receive the holy trinity of the correct treatment of their hearing loss. And I should mention, I get a little bit nervous when I talk about the holy trinity of the correct treatment of hearing loss. A few weeks ago, I was invited to speak at the this group. It's called U3A, or the University of the Third Age. They invited me to come along and talk about hearing and brain health. And they weren't in an academic setting like this. They actually held the session in a church. So I was up there in the. That's right. So I was up there in the at the altar preaching to the congregation about the Holy Trinity of the correct treatment of hearing loss, feeling a bit awkward about that. So the people in the study, they wore their devices at least 12 hours a day for a 12-month period. Then they came back into the university, had their brain scanned again, and underwent a range of functional tests. And what the researchers found was that the hearing centers in the brain had actually grown back in a way that we call statistically significant, which is to say they didn't just grow back by chance. This was a direct result of them receiving consistent stimulation through to those areas. Probably my favorite study in the hearing health and brain health literature was done at the University of St. Louis. Parts of it were replicated in Australia at the University of Melbourne. And what the researchers found in this study was evidence of what we call cross-modal reorganization occurring in the brain. Basically what they meant by that was that they saw evidence of shrinkage of the hearing centers in the brain. And this was done with 26 people that had a mild hearing loss. So even at mild levels of hearing loss, we're able to observe physical changes in the brain. So cross-modal reorganization, basically that they saw evidence of the visual centers in the brain starting to encroach upon the hearing centers in the brain. And how they were actually able to demonstrate that was by flashing visual stimulation into the eyes of these people. So, and what they found was that visual stimulation actually showed up in the hearing centers in the brain right here, which it shouldn't be there. And what this meant in terms of functionality for these people is that they found that these people with mild hearing loss, they performed significantly worse for hearing in background noise in groups versus those people that had normal hearing. They also found that they performed significantly worse on a range of cognitive tests compared to people that had normal hearing. And they kind of theorized, oh, well, if the visual centers in the brain are starting to encroach on the hearing centers in the brain, does that make these people better at lip reading? But what they found was that these people were no better on average at lip reading than people that had normal hearing. So again, they received holy trinity of the correct treatment of their hearing loss. So good quality, appropriate for them hearing devices, fitted using best practices, which we should always use. They weren't as strict in this study. They wore them for at least 10 hours a day. They then came back into the lab 6 months later, had their brains scanned again and did all those tests again. And what the researchers found was evidence of that trend had reversed. So when they flashed visual stimulation into the eyes of these people, it only really showed up in the visual centers in the brain where it should be, and it got out of the hearing centers in the brain, which is good evidence that as a result of receiving the proper stimulation, the brain reorganized back into a way in which it really should be, and that was evidenced by the improved functionality that these people have. They perform significantly better for tests for hearing and background noise in groups, and they perform significantly better on a range of cognitive tests. So I had the pleasure of going over to Texas last year. It was nearly a year ago now, and it was just an intensive conference on hearing and brain health. And the head researcher for this study, Dr. Hannah Glick, explained the results and everything in detail. And she described a study that they did after this, where they kind of thought, well, we're getting these quite dramatic results in kind of a lab environment. What if we go out and find 100 people that own hearing aids out in the community? Let's bring them into the lab and scan their brains, put them through all the tests, and let's see what we find. And basically, what they found in that study was that for 40% of people that were just out in the community wearing hearing aids, 40% were getting this kind of nice, visual centers in the brain were doing their job. They got out of the hearing centers in the brain. But for 60% of the people, it almost looked like they hadn't worn a hearing aid for a day in their whole life. And what they found was that when they kind of looked at the detail was that these people were, it was quite clear that the hearing aids hadn't been set up using best practices, and that they were what we call underfit. That's quite common when hearing aids are set on factory settings. So where patient comes in, the clinician does like a computer factory kind of estimate. Usually that's nowhere near enough volume that people need to be successful with their hearing devices. They also found that a lot of these people really weren't wearing their devices consistently. And she was, as part of her presentation, she just expressed that deep concern about this trend that we have here in Australia and over in the United States that happens as well, where people tend to put off doing something about their hearing loss for at least 10 years, because they did another study where they saw a guy who suddenly lost half of his hearing, and they found that this disorganization effect was happening in his brain in a 3-month period. So this stuff all happens like pretty quickly. There is good evidence that when we put off, we've got a bit of a window of opportunity when the hearing centers in the brain are understimulated for 10 years or more. We can see a bit of a permanent pruning away of some of those connections, and it makes it quite a challenge for us clinicians to deal with. It's really it's quite a basic process to assess whether someone has a really delayed treating their hearing loss too late. There's a simple test that we do in the clinic where we have our patients just repeat back some basic words. Almost always when I see someone who's got a hearing loss that's been around for 10 years or less, almost always they get 100% on those tests. When I see someone that really has put it off and put it off and put it off, it becomes, if it's been around for 10 to 12 years or more, it's very, very difficult for them to get 100% on those tests, because we start to get some distortion coming into the system. Generally we can help, but it starts to sound like things are like the radio's off station and things like that. So, really the sooner the better. But just in attending that training with Dr. Glick, I had a bit of a look at I guess, because I'm somewhat aware of the underutilization of hearing aids here in Australia, of people that own them, the studies that look at, well, how many are sitting in the top drawer and things like that. And in the United States, of people that own the hearing aids, several studies have shown that on average they wear them for about 10.8 hours per day. Whereas here in Australia, it's more like about 6.7 hours a day on average. And the key difference, I guess, because I've worked over in the United States prior to coming back here and starting my practices, the key difference in terms of the profession of audiology over in the United States compared to here is, well, Australia is actually quite unique relative to really anywhere in the world. We have the most corporatized expression of audiology. that really exists anywhere in the world. So most of the hearing clinics out there, particularly the kind of the chains of clinics, most of them are owned by overseas corporate chains. Most of those are owned by hearing aid manufacturers. So the thing is, like when you go to one of these clinics that's a manufacturer-owned clinic, you can have any hearing aid that you like as long as it's the specific one that they make. And in our experience, we do a lot of fix-up jobs in our clinic, and we do see people that are fitted with a solution that's just not really appropriate for their condition. Because the thing is, there's not one manufacturer that makes the right hearing aid for the right patient for the right lifestyle every single time. And even when they do, what we're seeing now with a increased rate of improvement in technology is that what is the right solution for a particular patient today, 6 months, 8 months later, it's likely that there's an alternative that's likely to serve that person better. And unless you're an independent clinic, you don't have all of that choice. So here over in the United States, 66% of the clinics there are independent, so they're kind of run and owned by a person like me. They've got choice of all of the manufacturers to choose from. And I find independent clinics are more likely to engage in the best practices that give us the best results. Here in Australia, only 7% of the hearing clinics out there are independent. So just a bit of advice. If you're looking to improve upon your hearing situation, I'd highly recommend that you seek out an independent audiologist. I'm not saying you've got to come to my clinic or anything like that, but they're not limited by choice. And in my experience, they're more likely to engage in best practices. So I'm going to give you just a very quick tutorial about how the hearing system works. I'm going to keep this pretty short. Tiffany, lovely Tiffany, who introduced me, she's actually my fiance. We're getting married in about 4 months' time. And last time I gave this, discussion about the anatomy of the ear, she rapped me over the knuckles and told me I kind of rambled on a bit. And I've been advised that you're engaged, you're about to get married. It would be in your best interest to actually do what you're told. So, so, I'm going to keep this. That's right. So I'm going to keep this short and sweet. So basically, how we hear is our sound comes through our ear canals, hits our eardrum. Hopefully you can see my little pointer there online. The ear canal actually is as unique as a fingerprint for each person. It's often quite different in shape from one side to the other. Some people get offended when I point that out, but it actually helps to shape the sound. It actually amplifies the sound in a way that's unique to you. Comes through, hits the eardrum, causes it to move backward and forward. The 3 smallest bones in the human body are behind the eardrum. They're about as large as half a grain of rice each, and they help to amplify the signal and direct it into the cochlea. So the cochlea is our organ of hearing. It's kind of like a snail-type shell here. And I've shown it a lot bigger than it actually is. It's actually about the size of a pea, and it has around 15,000 little nerve endings that sit inside it. And it's beautifully arranged, kind of like the keys on a piano, from low pitch right through to high pitch. So with those 15,000 little nerve endings, we're born with as many of those as we're ever going to have. So if at some point in our life, if we get wear and tear or damage to those nerve endings, they don't heal, they don't regenerate, they don't, there's no surgery, medication, or supplements that will bring them back. Once that damage is done, that it's done. So the cochlea, this is where, for well over 90% of people, that's where their hearing loss is. That's what's causing their hearing loss, is deterioration inside the cochlea in those little nerve endings. And when that happens, that's presenting a barrier or a hurdle for appropriate stimulation to get right through to the hearing centers in the brain. So further on, so this structure here, that's pictured there is just in different colors. So, we've got the high pitch here area here in yellow. This is the corresponding area here in yellow. The auditory cortex is probably the most important hearing center that we have in the brain. It too is split up from high pitch right through to low pitch. So if we've got damage in the cochlea, we're going to see a corresponding understimulation depending on the pitch at which that's occurring in the cochlea there. And what we can see with today's MRI imaging, we can actually see those areas physically start to shrink. Good news is, and we can get some disorganization effects with visual centers coming into those. Good news is when we apply the correct treatment, consistent stimulation through to those areas, we can see a reversal of that trend when we catch it in time. So this is what those little nerve endings look like. Actually, these were taken by Dr. Jim Pickles, who was 22 years ago. These were the best electron microscope images taken of the inner ear in the world, and it was done here at this university. And when those little nerve endings, 15,000 of them are intact, they stand up nice and straight like this, like soldiers. When they become damaged, they get all a bit kind of bent, twisted, and broken. They typically will still work when they're like that. However, we do need sounds to be louder. That's what a moderate hearing loss would look like under a really powerful microscope. So why I like to focus on the brain in talks like this, in the book that I've written, and in my clinic, is because we can say that our brains are plastic, or that we have neuroplasticity in our brains. When I say that our brains are plastic, does anyone have any clue what I'm talking about there?
Now,
Yeah, malleable. And I think someone said that they can change. Yeah, excellent. So yeah, in a nutshell, I think we're dealing with a pretty enlightened group here tonight, Tiffany. Sometimes I just get absolute stunned silence. No one's got any idea about what I'm talking about. So in a nutshell, neuroplasticity is a capacity for our brains to change. And there's really three main ways in which that can occur. So our ability to form new connections in our brains, that can actually happen at any age. There was a study done with a woman who was 113 years of age. So whenever we learn something new, we're forming new connections in our brains. 113 years of age, and they were able to demonstrate new connections being formed in her brain. So, if you learn something new this evening, then you're going home with just a little bit of a changed brain. Second way in which our brains are plastic is via our capacity to strengthen the existing connections in our brain. So whenever we practice a skill really well, or we learn something really well, we're improving the strength and the speed of those connections in our brains. The third way in which our brains are plastic is via a process that we call pruning, kind of like pruning a tree. So let's say, for instance, you learned something new this evening, you formed new connections in your brains, you went home and you tossed the book aside, didn't talk about what you learned at the seminar. Chances are that those new connections that you formed in the brain will in fact prune away. Depends on the part of the brain that we're talking about in terms of how quickly that pruning process occurs as a result of underutilization or understimulation. With the hearing centers in the brain, the science indicates that it's around 10 to 12 years of understimulation in those hearing centers in the brain. We can start to see a permanent pruning away, and that's when we can start to observe distortion happening in the system, and it becomes quite a challenge for us audiologists to get a really great outcome in the clinic. So can anyone tell me what the #1 cause of hearing loss is? Oh, really? Oh, wow. Yeah. Oh, gee. Crazy. So, sure, accidental causes would be about number 5 on the list. Yeah, that tends to be a consequence of hearing loss. So yeah, but in terms of so noise exposure, in terms of what causes it. So overexposure to noise, that's the second leading cause of hearing loss. Genetics. So there's some specific genetic conditions that would be number 3. Age. Who said age? Oh, well done. Excellent. Yeah, great. So aging is actually the number 1 cause of hearing loss. Why is it the number 1 cause of hearing loss? It's because it'll happen to essentially everyone that lives to be long enough. But there is a genetic component to that as well. So the rate at which we call it presbycusis, the rate at which that happens when it starts to kick in, there's quite a strong genetic component as well as an environmental component. Same applies to noise-induced hearing loss. Is quite a spectrum in terms of how susceptible we are for noise-induced hearing loss, and much of that is genetic. So sometimes people want to blame someone about their hearing loss for their hearing loss, and I tell them, well, you've got 2 people to blame. And they're called your parents. Okay. Yeah. Yes. So stress. So and the pretty much anything that will age you prematurely, including stress, will tend to accelerate hearing loss to some degree. So, in terms of preventing hearing loss, there's really 2 main things that we can do. One is avoid overexposure to noise, and really anything that you can do to slow down the aging process will tend to have at least an indirect benefit on your hearing ability. So that's great. And
Andrew, you said aging?
yeah. Yeah, I'd say result of infections. Yeah. And okay, so I'll just say one thing really quickly. If there are further questions, if you could be so kind to, we're going to have a bit of time at the end for questions, because the thing is, when we just if it's all about questions, I go off on tangents and we don't get through all the material. But tinnitus, so ringing in the ears, that's I've done specific seminars on tinnitus because it's kind of a whole topic on its own. It tends to be a symptom of hearing loss. But what we'll do is we'll come back to the topic of tinnitus a bit later in the seminar. And actually, I might mention it now. Tiffany, you've got the forms.
I just want to speak to the book. I think
Yeah, I've got a little bit about tinnitus in there. So, but one thing, I'll just mention this form because there's a part of it on there. So, so on this form, and for people that are listening via Zoom, there's a little survey when you get off the call. There's a little that asks to participate in the survey, and that's all these questions on there, and you can request this information as well. So, basically, Tiffany just passed out a feedback form. So if you get a minute to fill that out, it's really helpful. It lets us know that you've attended and gives you a bit of an idea about who's coming to our sessions. Also, there's a question there, a bit of feedback on the session if it's too long, too technical, that kind of thing. It's helpful to get that feedback. But about halfway through, just on question 2, it asks about tinnitus. So tinnitus, we can also call it a ringing in the ears. If tinnitus is an issue for you that you'd like to learn more about, if you can just tick yes, please send me free tinnitus resources, and we've put together a rather comprehensive guide for tinnitus that has, I guess, what the best facts that we have on tinnitus. So we send that out complimentary. And we'll talk a little bit about tinnitus at the end, but part of the treatment really for anyone that has tinnitus is to learn the facts about it, because the better we can understand the condition, and around 70% of people with hearing loss also have tinnitus to some degree. The better we can understand the condition, the better we're able to deal with it. And part of the concern with tinnitus is that people get worried about it, and the more, and a lot of that can be fear of the unknown or some rubbish that they read on the internet about it. But when we can understand the facts about it, then we're much better able to actually manage it. So, so if that's of interest, just tick yes on that form, and we'll send you out some good information on that. So I'm guessing most people here have had their hearing tested at some point before. Yeah. So you might be familiar with this graph up on the screen. We call it an audiogram. So an audiogram, it's like a snapshot of your hearing ability. So when your hearing is absolutely completely normal, you're going to test right along the top of the graph like that. We test the low pitches at this end and the high pitches at this end. And the further down the page we need to go, the louder the sounds need to be for you to hear them. So we test the right and the left ear separately, right with circles, left with crosses. And what I've done just up on the screen here is I've superimposed just a really typical age-related hearing loss that we see all day, every day in the hearing clinic. And basically we've got the circles here, the circles and crosses. They're in better shape in the low pitches, so they're up further toward the top of the screen. And as we go down, you can see that sloping down there. That means that this person's hearing the low pitches better than the high pitches. So the pitches that the frequencies, the pitches that we test in audiology, we're really focused on the speech spectrum. So our main priority in audiology is to assist and help with communication. So a question in our mind when we're testing hearing is to look at, well, how might that hearing loss be impacting on day-to-day speech understanding? So someone with a hearing loss like that, they're not going to hear all the sounds that are occurring in this light blue area here. They will in fact be able to hear all of the A, E, I, O, U vowels. Where the challenges will be are with these softer, higher pitch consonant sounds. So with a hearing loss like that, there's a bit of filling in the gaps that will need to occur to be following conversation. So we're going to have just a little bit of an exercise in that, just to give you a bit of a sense on this. You know, if we're thinking about I guess the core aspects of how our hearing health can relate to our brain health, this is a bit of an exercise in cognitive load. So if you just look up on the screen here, we can say that this is a text message. Just wondering if you're able to work out what they're trying to say there. You're getting the benefit of all the consonant sounds. All right. Now I'd like you to try it with an age-related hearing loss. So you're getting the benefit of the vowels there. So in communication, vowels they give us the perceived volume and loudness of speech. You know, we know someone's talking. If we're hearing primarily vowels, it sounds like people are mumbling. We know someone's talking, but we're just not getting the clarity of what they're saying. A lot of people get a bit that I see are a bit confused as to whether they've got a hearing loss or not, because they, you know, they feel they're getting the volume, they know someone's talking, but just getting the clarity and the meaning, that's like the main issue, which is a good sign that they may not be getting all of those consonant sounds. And so this is that's the actual sentence there in full. So, which you may have guessed with the benefit of the consonants only. So we're just going to have about a 5 or so minute break now. I'm going to talk just a bit about dementia now and how that relates to our hearing. So dementia, it's not a disease in and of itself. It's a description of I guess a cluster of symptoms. There's different causes of dementia. So Alzheimer's being I guess the most common form of dementia. We won't go into all the different types, but one of the ways in which someone may be diagnosed as having dementia or not is via the significant presence of at least 2 of the following issues here on the screen. So right up the top here, which you may have actually predicted, is in fact memory loss. It's kind of a primary consideration when one's considering a dementia diagnosis. So okay, all right. I'll take that on board. Thank you. Kind of depends on the projector. Sometimes it's really clear. So memory loss, it's a primary, and it's not another test, by the way. It's not another test. So how does it relate to our hearing? Well, we've known for decades that our memory loss, the more effort we need to be following conversation in a background noise and group situation, then the less of that conversation we're likely to remember. When we look at brain scans of people with long-term untreated hearing loss, we can in fact see impact on the memory centers in the brain, particularly the hippocampus. So if we get to it, I'll describe briefly a study that was done that was published just last week that observed that effect. And if we think about, I guess, our cognitive abilities, probably our most important cognitive ability is our short-term memory. So for most people, short-term memory, we can fit up to 7 bits of information at any one time. You might recall when home phone numbers were 7 digits long, then they were much easier to remember than, say, like a mobile phone number. 7 bits of information, it really isn't very much, particularly if, just say, we're in a background noise or a group situation. We're trying to separate that speech out from noise, and we're not hearing words in full in order to communicate. We're putting the bits that we can hear into our short-term memory, pointing that hopefully with bits that we can see, body language, facial expressions, movement on lips. Sometimes that's not enough, and we need to add in some context to that. That all goes into short-term memory. So when we're talking about a flowing conversation, 7 bits of information at any one time, it really doesn't take a whole lot for our short-term memory to really start to overload and to saturate. And what we know about short-term memory is that the more overloaded and saturated it becomes, the less resource there is for encoding into long-term memory. So what we're seeing are clear links between memory loss and hearing loss. As we go down here, the next on the screen is communication difficulties. So communication difficulties, I guess the primary concern about communication difficulties, and of course hearing loss results in communication difficulties, is that impact it has on the interaction with other people, and that risk of chronic social isolation that really comes with that. And I think it's worthwhile just to point out the unique nature of hearing loss relative to just about any other health condition out there. I particularly like to compare and contrast hearing loss and vision loss. So we know that most people here in Australia, people are 5 times more likely to address a vision loss than they are a hearing loss. But the thing is, if you just say you've got a vision loss and you're experiencing the the inconveniences about that. And I'm talking about like a partial hearing loss, partial vision loss. If you go and get that treated, say new set of glasses, or you might even get some cataract surgery, and you're treating that vision loss. Well, things are better for you. You can perhaps drive more safely, or read the paper, or menus, things like that. But you treating your vision loss doesn't necessarily have a direct impact or bearing on the quality of life or well-being of really anyone but yourself. And the same could be said about just about any other health condition that you have seen to. The thing is with hearing loss is that usually it's other people that notice it first. Usually it's other people that are they're more concerned about the hearing loss than the person that has it, particularly family members, spouses. And when we measure the outcomes, the benefits of treatment, often we see spouses in particular are more they're more satisfied with the treatment than the person that's actually received it. So it's quite so it's quite a unique health condition from that perspective, in that the impacts of that hearing loss they're often reach, say, far beyond the individual person that has it. So clear links between communication difficulties and hearing loss. Next on the list are attention deficits. So attention deficits in this context are the whole host of our cognitive abilities that relate to our ability to sustain attention, to focus attention, to divide attention. These become impaired when we've got a hearing loss that we've done nothing about, and that can actually start to take away from other faculties, including balance and steadiness. So we know that falls are the leading cause of accidental death for people in Australia over the age of 65. And having a hearing loss significantly increases one's risk of having a fall. A number of studies have shown this. Just one that I'll share with you. It was done on 20,000 men aged 60 that had been admitted to hospital for one reason or another. They had the hearing test records of these guys and the reason why they were admitted to hospital. And what they found was that these men that had a mild hearing loss, so about a 25% hearing loss, we never used to care about it. Those men with a mild hearing loss, they were 3 times more likely to have been admitted to a hospital because of a fall compared to their same age peers that had normal hearing. And for every 10% of additional hearing loss, that falls risk doubled in these guys. So why would having a hearing loss impact on our risk of having a fall? Well, first of all, there's 2 main reasons. The less well you can hear your environment, the less well you're going to be able to respond to it. So if you miss a step, or you tread on a toy, or if you're outside and tread on a twig, or you've got bikes whizzing by and things like that, then the less well you can hear those things that are going on, the less well you're going to be able to respond to them. But the main issue that the researchers put down to that increased falls risk is that consistent cognitive load that having a hearing loss puts onto our attentional capacities can start to take away from other faculties, including balance and steadiness. Further down the list, we've got reasoning, judgment issues, visual perception challenges, not so related to our ability to hear well. But if we're thinking about the top 3 criteria of thinking about a dementia diagnosis, the top 3 criteria relate, most of them relate directly to our ability to hear well. So dementia prevention has become quite a hot topic. In Australia, dementia is now the leading cause of death for women, the second leading cause of death for men, followed by coronary heart disease. And over the past 10 years, dementia-related death has actually increased in Australia by 68%. And coronary heart disease, leading cause of death for men, has actually decreased by 19% over that same period. So the medical community really have become better at treating different parts of the body. When it comes to actually treating cognitive decline or treating dementia, medical community really haven't got very far, despite the billions of dollars that have been spent on pharmaceutical interventions. The reality is at this point in time, we don't have effective treatment for these diseases of the brain. When it comes to cognitive decline, all we really have is prevention. So the Lancet Journal have done 2 major reviews looking at, so Lancet Journal is a medical journal, particularly in relation to brain health. It's considered to be the most prestigious medical journal on the planet. They've done 2 major reviews on what does the world's best science tell us about dementia prevention. And what they've found is that, well, they've come to the conclusion that up to 40% of cases of dementia could be prevented through long-term lifestyle modification. And they've come up with essentially the top 12 things that we can do to help reduce our risk of developing these diseases of the brain. And they've kind of rank ordered these in order of significant and effect size that they could see in the research. So if I go to the second on the list here, so second on the list is less education. So, and for adults, the remedy for that being developing a habit of lifelong learning. So I'd just like to, I guess, applaud you for, all the things you could be doing right now to take time out of your schedule and come and join us. And, hopefully you're learning a thing or two. I just urge you to do what you can to make lifelong learning a priority, because it really is one of the best things that you can do for your brain health. Right up on the top of the list in terms of modifiable preventable risk factors is in fact hearing loss. So the Lancet Journal defined hearing loss as being the #1 modifiable risk factor for the prevention of dementia. Modifiable meaning that there's actually something you can do about it. So why would hearing loss be at the very top of the list? Well, we know that hearing loss is really common. It's going to happen to just about everyone that lives long enough. We know that the impacts on our brain health can be devastating. And we also know that hearing loss is highly treatable. And when it's the right treatment, when it's fitted properly, and when it's worn on a really consistent basis, it's really effective. And the thing is, treating hearing loss, it's actually, particularly in this day and age, the technology is such that we can get our results rather rapidly. Most people that see me in my clinic for the first time that are open for treatment, most people can go home hearing better that same day. And the kind of performance that we're getting from, particularly over the last 3 years or so, is just way better than it used to be, thanks to the progressions that we're seeing in technology. But as we go down the list here, we've got so hearing loss, less education, smoking's there. I'm not sure how many smokers there are here, but the next 2 are interesting because they also relate to hearing loss, and they are depression. So we've known for decades that there's a significantly increased risk of depression in people that have hearing loss, and also social isolation, which we've touched on already quite a bit. So if we look at the, what the world's best research is telling us about dementia prevention, if we think about things that directly relate to our hearing or indirectly relate to our hearing, more than half of the things that we can do to help reduce our dementia risk either directly or indirectly relate to our ability to hear well. So social isolation, actually physical inactivity, we know that probably because they're not out and about socializing quite as much, people with hearing loss tend to be less physically active, more likely to be depressed. And if we're serious about developing a habit of lifelong learning, it's going to be helpful for us to be able to hear well, and also to have our cognitive faculties in good shape. So actually, I'm just going to ask you all just a quick question, and this is not I'm going to ask you a question. This is not a trick question. I know that we're in a seminar about hearing, and I'm an audiologist. There's no particular right or wrong answer here, but I'm just going to ask you to imagine if if you had to make a choice as to whether you keep your hearing or keep your vision. So the decision to make here is whether to become completely blind or completely deaf if you had to make the choice. So when faced with that decision about to be completely blind or completely deaf, who here would choose to keep their vision? Right. Excellent. And who here would choose to keep their hearing? Right. Okay. Okay. All right. Excellent. Now I'm going to put a couple of you on the spot now, if you don't mind. So, lady with the glasses, just on the end there, you put your hand up for hearing. Do you mind if I put you on the spot and ask, well, what is it that made you make that choice?
With this like music too much.
Okay, Miss Music, yeah, okay, sure, excellent. And the gentleman toward the back there, yeah,
Communication.
yeah, okay,
I think the communication thing
Right.
made it right.
excellent.
You can get around and you can do things without vision.
Yeah, sure. So for the benefit of the people on Zoom, the lady here said she'd keep her hearing for music. The gentleman said communications, the primary thing. Who else chose hearing? Okay.
Communication.
Okay. There you go.
An elderly person,
Uh-huh.
very active person in the family, just disappear, sit in the corner of a room while the family has the
Right. Okay. Yep. So the lady here, there's a communication because you've seen that in action. Well, when we ask that question in formal research settings, 83% of people will choose to keep their vision, 17% will choose to keep their hearing, and I see a pretty here I think we saw a similar kind of a split. It was around about 83% and 17% for hearing. The thing is, though, I think we must be dealing with a bit of an enlightened group here, because when people are put on the spot and asked, well, what is it about you hearing that would make you choose that? And it's not like there's right and wrong here, but people say things like we can say that they're kind of aesthetic things. So so the sounds of nature. So people say, oh, I couldn't live without the sounds of nature. I couldn't live without music. Music's fantastic, and so on. Or people even say, babies crying. I like to hear babies crying. Now, how hearing babies crying is your favorite sound in the whole world, I've got absolutely no idea. But it comes up. So, but very rarely does communication ever come up. And I know, actually, I asked this question. I did a talk in Melbourne with there was about 100 people there, and the only two people in the audience that put their hands up for that would choose to keep their hearing in that whole 100 people was a husband and wife, and they were both ophthalmologists, so they were vision surgeons, both of them, and they've been doing it for 40 years. So I did what I usually do, and I put them on the spot and asked them, well, what is it about you? Why'd you choose hearing? They said, oh, we're both ophthalmologists, and in the course of our work, we see people that do go completely blind. It's just the nature of the work that we do. Some people have comorbidities, so the thing that made them blind may have also affected their hearing. Sometimes they get their vision back, but in their observation, the impacts of deafness are just way more devastating for the people that actually experience it. Whereas in their experience and also in the research, there's indications that although there's obviously lifestyle adjustments, people that become completely blind on average are no less happy 12 months later once they've made all those kind of accommodations. I think people tend to be a little bit more sympathetic to helping people that are blind versus hearing's a little bit more invisible, but the impact on communication, I think, is really the primary thing. And in the, I guess, the course of doing this kind of work over a few decades, I just tend to find that, and I think it's, in that, we know most people with hearing loss do nothing about it. We know people put it off for at least 10 years on average. There comes a point in time, and I think, in my view, that communication is just something that we tend to take for granted until it reaches a point where it gets near on impossible. That's when we really notice just how kind of valuable it is. So, but thanks for your contribution to that. So earlier on, I talked about some statistics that looked at increasing levels of hearing loss with increasing levels of dementia risk. So that was done with Professor Frank Lynn's team. And after that research was published, they started to look at, the mechanisms behind hearing loss and brain health. Well, we know what's happening when we've got an untreated hearing loss. What happens when we apply the correct treatment to that hearing loss? And we do this in a way that is just very well designed studies using a gold standard of research techniques, quite expensive. They secured $40 million of funding for this research. Took about 7 years to get this study done over 7 different universities. And basically what they had, there was 1,000 people in this study. Half of them got hearing aids, half of them didn't. And they were treated over a 3-year period. And what they found was that people in the study that were at risk for cognitive decline, compared to those matched people in the study that didn't wear hearing aids, those that wore hearing aids, the progression of their cognitive decline was essentially cut in half relative to those that didn't wear hearing aids. And they saw on average, as a group of those people that wore hearing aids, they saw no degradation in memory abilities relative to, and which we couldn't say the same for those that didn't wear hearing aids. So just to, I guess, summarize the study, in older adults at increased risk for cognitive decline, hearing intervention, well-fitted hearing devices, slow down loss of thinking and memory abilities by 48% over a 3-year period. 48% slowing of cognitive decline over that period. It's massive. We don't see any, there's certainly no medications show anything like that, let alone really any other intervention that at least I'm aware of. There were another 3-year study that was done over a similar period. It was only just published in January this year. 160 people in this study, and basically what they were looking at is the difference in cognitive abilities in people that got fitted with hearing aids versus those that didn't. And they did this down in Melbourne, and they had a check-in at halfway through the study at 18 months. And what they found was that people that wore hearing aids showed improvements across 5 different domains of cognitive function relative to those that had didn't receive hearing device treatment. And then COVID happened, and this is all down in Melbourne, and there was the notoriously long lockdowns that occurred, particularly in Melbourne. And what they found was that the average time at which they were wearing the hearing aids reduced as a group. I think it was they were wearing them for around 10 hours a day on average, and that dropped down to around, I think 7.8 hours a day on average. So people were at home, they were locked down, they weren't wearing they got out of the habit of wearing the hearing devices, and they also weren't interacting socially as much. And what they found was that they still maintained improvements in cognitive abilities over 4 dimensions, but they dropped off on a 5th, which is executive function, which is like the integration of a lot of these these cognitive abilities. And whilst there's a relatively small study, I guess the takeout that I there's 3 takeouts. One is that good evidence that hearing aids help with cognitive function, but it's really important that those devices are worn on a really consistent basis. and also really important that, one of the benefits is facilitating that really important social interaction and communication with other people. Another study was just published a few days ago, and they looked at the hearing test results, and they took brain scans, did a range of tests, hearing test results of people aged 70 that were all born in the same week. I think there was about 250 people in this study. And they tracked them over a 2.5-year period, and what they found was that they found that their hearing level on their audiogram, so that test where we're looking for the softest sound they can hear, that predicted the amount of degradation in the hippocampus, which is just a really, the hippocampus provides a pretty central function for our memory, particularly formation of long-term memories. The level of hearing loss that they had was a predictor for how much that hippocampus was impacted over that period. So what we're seeing here with the research in looking at impacts of hearing loss on brain health is just really consistent. When I started really looking into this and started giving these presentations or similar ones about 4 years ago, I was just waiting for some evidence to come out to kind of refute some of these claims. But what we're seeing is just a confirmation and a better understanding of all these mechanisms. So I want to talk just a little bit about social isolation now. And there's a couple of studies that I'd just like to discuss. One being one of the longest running studies that's ever been done. It's often called the Harvard Happiness Study. It started off as being essentially a study looking at what is it that makes a happy life. So basically, there's a very longitudinal study. So the researchers thought, well, let's track people over their entire lifetime, and let's see if we can get an understanding of what is it that makes a happy life. And basically, that's kind of morphed into the research question. Well, what is it that the people with the highest level of well-being, what is it about them and their lifestyle? Is it how much money they make? Is it the kind of job that they have? What is it that makes a really happy life? So they track these people over their lifespan, and they've started to look at the children and extended families and huge amounts of even looking at the brain scans of these people and so on. And what they've come to the conclusion, like the overwhelming conclusion, that the people that have the lowest levels of well-being are the chronically isolated and the chronically socially isolated and the lonely. They found in the study to have smaller brains, the life expectancy is lower, and significantly more likely to suffer from depression. On the other end of the spectrum, those people that had the highest levels, consistently the highest levels of well-being in the study, were those that had the best quality close relationships. So wasn't necessarily the most relationships, but it was of those close relationships that they were of high quality. And if we were to think about, well, if relationships are key, what is it what's an ingredient that really kind of needs to be there for a relationship to be of high quality? Anyone like to contribute there? Communication? Yeah, great. And I think we can all agree that at least on some level, communication is rather fundamental for any relationship to be of really high quality. Next study that I'll share relates to what we call the blue zones. You might have heard of the blue zones. They're different parts of the world where people are just more likely to live to be over 90 or even 100 years of age. There's several blue zones. There's one in the United States, one in Japan, and they're studied quite intensively. And what researchers are trying to find out is, what are these people doing in these little areas all around the world? that helps them live such a kind of long and happy life. And they found similarities, and there's consistent trends across them. In fact, there's a Netflix series that came out a couple of months ago called The Blue Zones. It's worth having a look at that. But they found an exception in one of the blue zones in the island of Sardinia, which is just off Italy. They found that, so in all of the other blue zones, in all of the blue zones except this one, they saw the same trend in life expectancy that they see here in Australia and, you know, the rest of the Western world, where women outlive men by close to 8 years. So that happens in all of the blue zones. So typically it's the women that are living to be over 100 years of age, except in Sardinia. What they found was that there was really no difference in the life expectancy between men and women in these communities. And so, you know, these guys, they're under a microscope, these guys. What is it that they're doing differently compared to all the other blue zones and, you know, these trends that we see in the Western world? And what they found was that they couldn't see any difference in the ways in which men prioritize relationships relative to women. So men were just as likely as women to put in high priority family gatherings, family engagements, would put as a high priority to spend time with their friends. And there was no difference in that relationship orientation that men had in these communities. So I sometimes get a bit nervous. It's been 22 years since I was actually studying in a university, and I get a little bit nervous because apparently I'm not sure what it's like here, but there's a belief out there that there's no difference between men and women, but. But you know, if we look at objective data, then you know, we can see that there can be a difference in terms of orientation, interest, and proclivity. And you know, on average, and there are exceptions, what the data tell us is that, you know, in the Western world, men tend to have a proclivity to things, whereas women tend to have a higher proclivity to people. And what they found was that these guys in Sardinia, they had a pretty equal proclivity to people as women did, and that was really the core factor that the researchers could identify that explained their longevity and, you know, kind of approach to life. And the thing is, what they found was that you know, that these guys they're interviewed intensively, and what the researchers found, they got the overwhelming sense that these guys kind of took it for granted, that it wasn't like they were, you know, prioritizing relationships because they knew it was like, you know, really great for their well-being and their longevity. It was just kind of like a way of life for them. It's just what they knew. So there's this you know, observation that it was something that they kind of like took for granted. Just reminded me a little bit about, I think, our tendency to take communication for granted, and it's really not until it's taken away until we really start to value it a whole lot more. So in a nutshell, if we're thinking about, well, what is it about our hearing? How does our hearing health relate to our brain health? There's really three main things that we've touched on all of these, at least briefly. Brain overload, that cognitive load that having a hearing loss puts on our cognitive abilities, that increased risk of social isolation, and that cerebral atrophy, so that brain shrinkage, that reorganization effect that we can see in our brains. But what we're also seeing is that that when we treat that hearing loss correctly, we can start to alleviate a number of these things. So in terms of blindness and deafness, just to wrap up that particular topic, there are people in the world that have been deaf, either deaf and blind, and you know, become you know, if they've got their vision back, sometimes they've you know, got the hearing back with a cochlear implant and things like that. And those that have experienced both blindness and deafness, overwhelmingly, if given the choice, they'd choose to keep their hearing. Helen Keller, who was probably the most famous example of a deaf and blind person, she was the first deaf and blind person to get a university degree. She explains it like this: blindness separates us from things, but deafness separates us from people. So at our clinics, we're and I've got a couple of my patients here, and they'll tell you that I'm fanatical in the nicest possible way about keeping hearing devices in, ideally at least 12 hours a day. So we've kind of recently developed a program which has got a bit of a workbook for our patients, and occasionally we do workshops on this that we call our out-of-the-box workshops. The core message here that if we're going to be successful in treating hearing loss, those solutions need to be out of the box and actually being worn. And there's always a bit of an acclimatization period, and that our program kind of helps our patients through that. But we see it as the most important part of our jobs is to ensure that our patients are actually utilizing the treatment. I've been working with a charity in Cambodia since 2012. When I first went there, there were 4 audiologists. Now they've got 11 of them. So we support them in helping with their audiologists. Also support them in sending pre-loved devices over to Cambodia, because we know that there's tens of thousands of hearing aids sitting in top drawers, bathroom cabinets all around Australia. Or, there might be just hearing devices that have been replaced with new ones. If you have those, or someone that has hearing aids laying around the home, if you can send them into our clinic at Ashgrove, we fix them up and we send them over to Cambodia, where we know that they do actually get utilised, and they're completely dependent on that outside support. So just in closing, what I'd like you to consider, like you to think about hearing loss just like you would really any other major illness. Coronary heart disease, diabetes, cancer. There's no blanket cure for these chronic illnesses, but there are effective treatments, and your doctor will tell you that when those treatments are most effective when they're delivered early. We know that hearing loss is a progressive degenerative disorder with neurologic involvement, and we get our best results when we catch it early and we treat it early. So thank you so much for your time and attention this evening.